Namaste and good afternoon from all of us at Apollo Hospitals. We hope you're well, fit, healthy, and happy. This is Dr. Srinidhi Chidambaram welcoming you to our Facebook Live session for today. At Apollo Hospitals, with our motto of touching lives, we place great importance on creating health awareness among people, as we know that prevention of disease and early detection is crucial to better outcomes. And stroke is one such disease. You all know that a stroke occurs when the blood vessel, any blood vessel in the brain ruptures or bleeds, or when there is a blockage in the blood supply to the brain. According to the Indian Stroke Association, the incidence of stroke in India has increased exponentially in the past few decades. And it is said, as per an ICMR report, that it is the fourth leading cause of death and the fifth leading cause of disability in India. Ischemic stroke is one of the types of stroke and is also one of the commonest types worldwide. And this is the one which is caused by the blockage in an artery that supplies blood to the brain. The blockage reduces the blood flow and oxygen supply to the brain, leading to damage or death of brain cells. So today we are going to delve deep into this topic of ischemic stroke, and we are going to address a very specific aspect of treatment of ischemic stroke, which is the cardiac monitoring after an ischemic stroke. To discuss this with all of us and enlighten us, I am very happy to welcome Dr. Prasanna Katti, who is a senior cardiac specialist practicing at Apollo Hospitals, Seshadripuram as consultant cardiologist with several years of experience. Dr. Katti completed his MBBS from BLDEA's Sri B.M. Patil Medical College, Bijapur in 2003 and his MD in General Medicine from the Karnataka Institute of Medical Sciences, Hubli, followed by a DM in Cardiology at the Sri Jayadeva Institute of Cardiovascular Research in Bangalore. He's a member of the Karnataka Medical Council and has been practicing for many years in the Apollo Hospital, Seshadripuram. Welcome, Dr. Katti. I'm delighted that you're here, and I look forward to discussing about the ischemic stroke as well as the specific cardiac aspects of monitoring post-stroke. Over to you.
Thank you, Dr. Srinidhi. I'll be extremely good afternoon, everyone. I'll be extremely happy to discuss certain things regarding cardiac monitoring and other things, particularly in patients with ischemic stroke. We'll have a discussion so that many of our doubts are sorted out, and we'll have a discussion regarding this.
Absolutely. Thank you, Doctor. So maybe we could perhaps begin for the viewers, like you could give us a bit of an overview about ischemic stroke itself, and then we can go on to the cardiac aspects of it.
Okay, I'll try to simplify it. Any decrease in the blood supply to the brain, we call it as stroke. Okay, it can be a mild form or it can be a severe form. And this loss of blood supply to the brain can be in two forms. One, there is a clot in the arteries supplying the brain that we call ischemic stroke. And today, predominantly, we'll be concentrating on ischemic stroke. Other, it can be due to the hemorrhage, that is bleeding into the brain area because of the rupture of a small artery, small vessel, that can also result in stroke. So, but majority of the times, if you take literature, 80 to 85% of the times, the stroke is because of a clot, that is ischemic stroke. And hardly in some 10 to 15% of the cases, it is because of the bleeding. We call it as hemorrhagic stroke. These two things are very important because with the current availability of, say, CT scan and MRI, we are able to tell immediately whether the patient has a ischemic stroke or a hemorrhagic stroke. So, because there is a huge difference in the management. In ischemic stroke, we have a lot of drugs to give, and we have to dissolve the clot and re-establish the circulation. And unfortunately, in a hemorrhagic stroke, we don't have much medicines other than reducing the blood pressure or reducing the intracranial pressure, that is pressure inside the skull. Or if there is a high pressure, and if there are any effects of compression, they may be subjected to surgery on emergency basis, particularly in a hemorrhagic stroke. There can also be a need of surgery even in ischemic stroke if there is a lot of edema and if there is a compression of the vital brain structures. We clinical terms we call as shift of the midline structures or compression leading to herniation. So in such cases, we may have to subject them to surgery. So when we talk stroke, that means it is nothing but lack of blood supply to the brain. It could be in the form of a clot or it could be in the form of a bleed.
So, what would be the causes of this ischemic stroke of the clot to form?
Okay. See, ischemic stroke we can classify into many types. And if you go to the etiology, from where the clot comes actually, as a cardiologist, when I look into my specialty, heart, the clot can generate from the heart. We know that the heart has many chambers. Four chambers are there, two upper chambers and two lower chambers. Upper chambers we call atrium and lower chambers we call it as ventricles. On the left side, the left ventricle, that is the lower chamber on the left side, takes the blood from the left ventricle to all over the body through a big artery known as aorta. We have an aortic valve between aorta and left ventricle. Think that there is a clot in either left atrium or left ventricle. Along with the blood, it can get pumped out to the aorta, and while it goes to the brain, it can get stuck in the brain and can result in stroke. It can also go to the hands, it can go to the legs, it can go to the abdominal vessels. When it goes to the brain, it causes stroke. That is, well, clot formed in the. Who are the people who get these clots in the heart? They are usually the patients with atrial fibrillation and patients with rheumatic valve disease, valvular heart disease. These people. They can also get stroke because of the clot. There is a tight block in the vessel supplying the brain. Those arteries are called as carotid arteries. If they are, that is we call in technical term as carotid artery stenosis. If there is a carotid artery stenosis or in layman term carotid artery block, significant like 70%, 80% or 90%, from there, whenever that plaque ruptures, the clot can get embolized from there. From there, it can go to the brain and result in a clot formation in a small vessel, resulting in stroke. Or the arteries of the brain itself, because of the atherosclerosis, can get affected by the blocks. That then they can result in clot formation and can result in stroke. So, starting from the heart, going to the carotid artery, which is a big vessel supplying the brain, or the small vessels, which branches of the carotid artery, which are supplying directly the brain, they can also have a clot and result in stroke. That is called ischemic stroke.
What are the risk factors apart from having this valvular heart disease or arrhythmias? Are there other risk factors that perhaps can be modified by any lifestyle changes? Anything that people should know?
Yes. When we call stroke, one important thing we should remember is whether the patient has atrial fibrillation or normal sinus rhythm. So one form is where patient has a atrial fibrillation that can result in stroke. It is very well established in the literature, and we have a lot of data to support it. So that is a different category. Another category of people is patients with normal sinus rhythm still can have stroke. So what are the risk factors is the same risk factors which are resulting, for example, heart attack, like high blood pressure, diabetes mellitus, high bad cholesterol, like high LDL cholesterol, and smoking. These are some important causes for having a stroke. So in that, other factors may be the age of the patient, stressful lifestyle that we call type A personality, lack of exercise, obesity, excess alcohol intake. These can also, and excess consumption of oral contraceptive pills without the guidance of the doctor, that is hormone replacement therapy. All of these can result in stroke, ischemic stroke. So, and coming to the heart diseases, valvular heart diseases can cause stroke. And also, if the patient develops a heart attack, the area of the myocardium damaged because of the heart attack may not pump the blood properly. So the blood will get stagnated there and result in clot formation. We call it as LV clot, LV apical clot that can get dislodged when heart pumps, and that can also result in stroke. These are some important causes. There may be some rare genetic causes also to development, but in our practice, usually in the community, for people, we see these are most important causes which can cause ischemic stroke.
Doctor, you were talking about a heart attack and how these cardiac conditions can generate the clots. Is there any, so how are they treated, like if somebody has a heart attack, and so how is this clotting tendency prevented? in such patients?
Okay, two things. One, what usually we see in these patients is whether they are suffering from atrial fibrillation. So that we do it by doing a ECG, and also if it ECG is not picking up, the one ECG may not pick up the atrial fibrillation if they have paroxysmal atrial fibrillation. That means atrial fibrillation comes in attacks and goes off. So that we have to pick up by doing the Holter monitoring, maybe for 24 hours, 48 hours. Sometimes we may have to record for 7 days or extended Holter monitoring we have to see, because we should not miss the atrial fibrillation because treatment is going to be entirely different. The other thing, modality, how we see is by doing the echocardiogram. So if the patient has a rheumatic heart disease, dilated left atrium, by doing either transthoracic echocardiogram, it is nothing but ultrasound of the heart, or transesophageal echocardiogram. Transesophageal is very simple. It will be just like an endoscopy. We take the echo probe to the esophagus, because esophagus is very near to the heart. So we'll be able to see the left atrium and left atrial appendage very easily from the esophagus. So we look whether there is a clot in the left ventricle or clot in the left atrium or left atrial appendage. Usually right side of the clots will not go to the brain. They will go to the lungs and they can cause pulmonary embolism. So by doing this, we can know whether there is a active clot or a we call soft clot or a mobile clot. Sometimes cardiac tumors can also cause stroke. We call left atrial myxoma. There may be a tumor attached to the left intra-atrial septum projecting into the left atrium, and it will be a fungated friable mass with a blood flow that can get dislodged and can go to the brain. Sometimes, many times we have seen cardiac tumor, the first presentation of the patient is stroke. They come to the hospital with stroke. So how to prevent this? To prevent, whenever there is a formation of clot, we have to give some blood thinners which will dissolve the clot. So these blood thinners will prevent one. There are two types of blood thinners. Whenever there is stroke happens, we have to lyse the already formed clot, and whenever we see a clot in the left atrium and left ventricle, and still the patient has not developed stroke, then we have to give some blood thinners so that the clot gets dissolved. Sometimes we may be forced to subject the patient for surgery and remove the clot.
So the other aspect is actually after the ischemic stroke, about the cardiac monitoring. So is there any scope, and what is the recommendation for that?
Okay, all patients with stroke, particularly ischemic stroke, should undergo some basic test. We are not doing any hi-fi test on these people, which are easily available in all parts of the country. One is we have to record a ECG in the patient. When they have stroke, usually for initial 24 to 48 hours, depending on the severity, the patient will be in the ICU, and then the patient will be shifted to ward once the patient recovers. This time, we continuously monitor, particularly in ICU, with the rhythm and try to record whether there is any episode of atrial fibrillation. Sometimes atrial fibrillation is picked up in one ECG, what we do. Then our doubt is cleared out. So we have to treat on the lines of atrial fibrillation. Then another important test we do is we have to do a echocardiogram, a proper echocardiogram, to look for a clot in the left atrium or left ventricle. If we have any doubt, then we have to subject the patient for transesophageal echocardiogram. Maybe once the patient recovers from stroke, maybe 4 weeks, because they may have a swallowing difficulty, then we have to do a transesophageal echocardiogram, like an endoscopy, check whether there is a clot in the left atrium and left atrial appendage, and if it is there, treat accordingly. So these two important tests we usually, and one more thing is Holter monitoring. So 24 hours or 48 hours, we have nowadays chips, simple chips to connect to the patient. They can go home and come back after the specified time. Then we analyze that data. We'll come to know whether the patient was sinus rhythm or intermittently patient was developing atrial fibrillation, so that we can change our treatment according to our diagnosis.
We will now look at some questions also from our audience. So the other aspect is that, like if some rhythm disturbance is detected after the stroke through the Holter monitoring or whatever, what kind of therapy will be started for the post-stroke patient with cardiac abnormalities?
Yes, any patients with stroke, again here we classify the if they have atrial fibrillation or not, we have to confirm whether they are in normal sinus rhythm. Treatment is going to change. Usually in normal sinus rhythm, we treat them with dual antiplatelet agents, like one simple substance everyone knows is aspirin. With that, usually we treat one more with another drug called P2Y12 inhibitor, either clopidogrel or one more new agent has come, which is ticagrelor. These, and with that we treat them with statins when we come to know that they are in normal sinus rhythm and that is heart is not the source of the stroke. Second category of patients is when they have atrial fibrillation. When there is atrial fibrillation, there are two important things. And for all stroke patients, one thing is common. If they are diabetic, hypertensive, high LDL cholesterol, smoking, that needs to be taken accordingly. Diabetes needs to be controlled, hypertension and high cholesterol needs to be controlled, and if they are smokers, we have to consult regarding complete abstinence from smoking. Coming to the atrial fibrillation. When atrial fibrillation, we look into again on echocardiogram whether they have a valvular heart disease. What is meant by valvular heart disease means whether the patient has a rheumatic valve disease or whether the patient has in the past has undergone a valve replacement like mitral valve replacement, aortic valve replacement, or we also look something called as myxomatous mitral valve, which is by birth. So if they have valvular heart disease, we call it as valvular atrial fibrillation. If they don't have valvular heart disease, if the atrial fibrillation is because of the hypertension, because of the age, because of thyrotoxicosis, some any cause, we call it as non-valvular atrial fibrillation. Atrial fibrillation can also happen without any cause. Then we call it as lone atrial fibrillation. We don't have any known cause to have atrial fibrillation. Still, it needs to be treated. When there is atrial fibrillation, first there are two things. One, we have to control them, look into what is the heart rate. If the heart rate is high, say 100, 120, then we have to control their heartbeat. That is one thing. That is called as rate control. Sometimes we have a scope to revert the rhythm from atrial fibrillation to sinus rhythm, either by giving a shock or by using drugs like amiodarone. We call it as cardioversion. When we use drug, we call it as chemical cardioversion. When you use a shock, we call it as DC cardioversion. Usually, we will not do a DC cardioversion in the presence of stroke. Suppose suppose the patient has a valvular heart disease, we have to use only the old blood thinners. We call it as vitamin K antagonist. They are available as warfarin and acetron. Valvular atrial fibrillation is there. There is no scope for using the new oral anticoagulants. So we have to use the old anticoagulant only. Here, what is one important thing is, I will come to the monitoring of these patients later. So when they have atrial fibrillation, but there is no valvular heart disease, a presence of valvular heart disease is ruled out by doing an echocardiogram, then we can use new oral anticoagulants, which are easily available in the market. And because the patency has gone now, most of these molecules are cheap now. Previously, these molecules were a little expensive. Because of the affordability is an issue in Indian setup, we should be very cautious because most of the time these treatments are going to be lifelong. So we have to use newer anticoagulants which are available in the form of dabigatran, rivaroxaban, and apixaban. So depending on the dose, looking into their kidney parameters, we start them with these medications.
What precautions should people with rhythm disorders take?
Yes, rhythm disorders patients, particularly in our setup, should be in regular follow-up with a cardiologist. If you go to western part of the world, you may have a cardiologist who will take care of your rhythm. There may be a cardiologist who will take care of your hypertension, ischemic heart disease. But in India, most of the time it is a general cardiologist in some metropolitan cities, electrophysiologists who are trained in rhythm management can take care of the patients. So first important thing is patient should always receive his medications from a qualified cardiologist. Any changes needs to be made, he has to be in regular consultation with the cardiologist. If the surgery is planned, if he wants to stop some medications, particularly blood thinner, it has to be in consultation with the doctor. Because if we stop abruptly any blood thinners, definitely that in a patient with atrial fibrillation, it is definitely going to increase the risk of ischemic stroke. Even we have seen in our clinical practice, patients who have stopped for even one day, few hours, or one day of anticoagulation, when they can come back with stroke. Patients can also still develop ischemic stroke even after giving the proper treatment. But definitely the anticoagulation is going to reduce the risk of developing ischemic stroke.
Is there any particular risk factor for these rhythm disturbances, as in, I think, for the atrial fibrillation?
Yes. See, for atrial fibrillation, basically the basic thing is the left atrium will be contracting against the mitral valve. When it pumps its blood, left atrium, that is left side of the upper chamber, receives purified blood from the lungs through the pulmonary veins, and it has to pump that blood to the left ventricle. So whenever the left atrium enlarges, or for that matter, right atrium enlarges because of the right side pathology, that is the basic substrate most of the time. But many a times the left atrium can be, the upper chambers can be normal. Still, these people can develop atrial fibrillation. Who are the people who develop atrial fibrillation? Is one in patients who have thyrotoxicosis, patients who have high blood pressure, patients who take excess alcohol consumption, one important risk factor. Age, elderly individuals, those who are in 70s, 80s, high chance of developing atrial fibrillation. Patients with ischemic heart disease with elevated left ventricular pressure because left atrium contracts at a high pressure and gets enlarged. Patients with valvular heart diseases like rheumatic heart disease, myxomatous mitral valve disease. Patients with some infiltration disorders can be in the form of restricted cardiomyopathy or can be hypertrophic cardiomyopathy. We call primary muscle disorder of the heart. These are the people who are patients with heart failure, that those who have a reduced pumping function of the heart. These are important subset of people in our clinical practice. 90% of the time they come with atrial fibrillation. Many a times we may not have a reason, as I told you, that is we call low atrial fibrillation. Young person may not be having either alcohol intake, not a hypertensive, doesn't have thyrotoxicosis, still he can come with atrial fibrillation. That we call it as low atrial fibrillation. So those patients also will require treatment for atrial fibrillation.
So, this has explained the whole cardiac aspect of ischemic stroke and the whole sequence of how clots can form and how they can be prevented. And you've also elaborated on what kind of monitoring is done in ischemic stroke, post-stroke on the cardiac front. So thank you, Dr. Katti, for this very illuminating discussion. And viewers, I hope you enjoyed this session as we delved a little deeper into the ischemic stroke management and the causes of ischemic stroke, and delved into how cardiac care is done post an ischemic stroke. It's always important to address serious diseases like stroke with the expertise of a multidisciplinary team, and because these kind of diseases can have different effects on different organ systems and they can all be affecting each other. So I think this was a very valuable discussion, Doctor. Thank you very much. And thank you, viewers, for participating. And of course, you know that stroke is one of the diseases where you must seek immediate medical attention. If you notice any symptoms or signs of a stroke, even if they come and go and if they are very fleeting too, you must take medical advice. And of course, you know the acronym FAST. Ask the person to smile if the face, one side of the face droops, or when the person is not able to raise both arms at the same time, or if the speech is slurred, then you know that you have to act fast and take emergency medical help. So please put in your queries and your comments on our Facebook page or inbox us on our Facebook Messenger, or look at our YouTube channel for other trending healthcare topic videos.
Thank you.
Thank you.
Dr. Srini. Thank you, viewers.
Thank you, Doctor. And please stay safe and stay healthy. See you soon. Namaste.